this year, we have made a plan to increase accessibility of our services to ultra-Orthodox people. We have decided to address the ultra-Orthodox society. This is because their accessibility problem is not only an issue of money or education, it's a real cultural thing. For ultra-Orthodox people, to make access to internet in their houses is a cultural threat. And therefore, the challenge was bigger. But we also understood that there is an opportunity in this community because they seek for a lot of high quality medical care. They understand the value of staying at home and not coming to the hospital. And we understood that there is an openness for that. Therefore, we decided to study this cultural challenge in depth and went for a 2-day journey to the ultra-Orthodox society with the help of Maoz organization. During these 2 days, we studied their needs. We met a lot of people. We went into patients' houses. We met organizations, healthcare organizations, and others, and leaders in the community. And what we understood after these 2 days is that it is possible and that there's openness to it. And therefore, we've decided to open a new services that is already from the beginning adapted to this population. The service we chose was home hospitalization for women who have postpartum depression. We have a specialized clinic in Sheba for this situation, and we adopted these services for ultra-Orthodox people. That means we not only did the changes that needed to be done technologically, we bought special tablets that are blocked and are kosher and are blocked to other data or internet. We adopted the protocols. We taught the personnel how to work with this community, and we got access to healthcare leaders or to community leaders in the society that will help us introduce this program to the people.
We are also currently leading 650 million shekel healthcare program for the Arab society as part of the government's decision for the Arab society that took place in the recent government. At the same time, and in the light of various data that we have begun to collect, we are promoting a plan to reduce health disparities in the ultra-Orthodox, the Haredi society in Israel. Another population that is in the focus of the unit is the population in the low socioeconomic situation. In almost every parameter, this is the least healthy population in Israel. We are trying to examine how the system can be better accessible to this population, as well as to promote collaboration with the various systems like the welfare system and the educational system.
So AHA has a long history of promoting health equity and supporting hospitals and doing this really crucial work. So we have two groups at the AHA that focus their work on health equity from different angles. So one is AHA's Community Health Improvement Group, ACHI, which I mentioned before, and that works on health equity from the community perspective. In other words, how can hospitals work outside of their walls and with community-based organizations to create the social, environmental, and economic conditions that allow people to thrive? And we see hospitals doing this work in numerous ways, through their community health needs assessment process, through investments in affordable housing, by setting up grocery stores in areas where they don't have access to food, advocating for broadband internet access. The list goes on, and we're seeing hospitals just develop really creative solutions to some of the issues that we face in U.S. society. Our other group is called the Institute for Diversity and Health Equity, and they really focus on what happens inside hospital walls. So thinking about how to make patient care more equitable, how to diversify the workforce, how to address implicit bias and provide culturally appropriate care. So AHA developed a framework to support hospitals and health systems as they address these non-medical issues that impact health. And the way that we've tried to conceptualize it to make this work more accessible for hospitals is setting forth 3 distinct yet connected levels so that hospitals can think at the person level how to address patients' social needs. So when a patient comes to see their clinician, they can get screened for things such as food and housing insecurity, and that provider can offer referrals to organizations to treat those needs. Going out to the bigger level, the social level, is what we're calling social determinants of health in the community. And those are the underlying social and economic conditions that influence people's ability to be healthy. This is where we're seeing hospitals working with their partners in the community to improve the environments where their patients live. And most broadly are these systemic causes of inequities, those fundamental origins of social inequalities such as racism, sexism, and poverty. This is where we see hospitals and healthcare organizations advocating for policy, system, and environmental and cultural changes to really change the environments where their patients are living.
At least in the United States, we now actually are able to fill the gaps that people have because of the $60+ billion in the broadband programs that are part of the Infrastructure and Jobs Act. There's actually money to make sure that people who can't afford internet can get it, and also a subsidy for purchase of a device. So the implication of that is that a health system or an insurance company or what have you should be screening people to find out what their barriers are to internet digital readiness, and then refer people to organizations in their community that are expert at getting people connected and helping people get basic digital literacy skills.
When the Russian war in Ukraine began, we understood we had a chance to be significant in this field as well. And when we understood that Israel is going to send a field hospital to Ukraine, into the fields of Ukraine, we decided to take action. What we did is we inflated a tent of Shiba Beyond within the field hospital. And in this tent, we actually deployed a consultation clinic. People will come, will translate their documents, will upload their imaging studies, and will consult with Shiba's top specialists. What we also did was reinforce the field hospital with technologies such as high-level point-of-care ultrasounds, VR goggles to help treat patients with trauma and other stuff. And the third thing we did was actually to train local healthcare clinicians using remote care technologies, and we also donated these technologies to these healthcare professionals with the help of the Joint Committee. Technology can help us a lot in providing a better continuity of care for these patients. If we know how to monitor patients in their homes, we can get a lot of actionable data, objective data of what happens with our patients between our encounters. And that gives us a lot of help for us and the patients as well in how to control their disease. The information that is also reflected to the patients can give a patient a better control of its disease and better adherence to the treatment. And also, later on, we'll use more algorithms and bots that will help us make better decision-making regarding our patients and will decrease the clinician overload.
Technology can be tricky when it comes to reducing gaps. On the one hand, with the help of technology, we can make treatments accessible to remote areas, to bring doctors from different kinds of the country to other parts of the country without them leaving their home or the clinic, and make other services accessible and a lot more. But on the other hand, technology can be a factor that widens the gaps because it's often developed for the majority of population. We usually develop the technological solution by people from the majority population to the majority population, and they often will be the first ones to adopt it. And this can be a very dangerous area that widens the gaps.
So what may be some of the technological solutions? How can we look at some pragmatic solutions that could actually help and serve populations better? So really one of the biggest divides is health literacy. And health literacy is combined with digital literacy poses a major problem for populations to really improve their health and health outcomes. So, for example, medical instructions today, discharge letters, are given really in medical terms. They are, if you're discharged from hospital and you want to understand what you've been through, the discharge letter you receive is not for the patient, it's actually for your family physician, and it's written in medical jargon. So if I'm a patient who's just been discharged and my Hebrew or native language is Hebrew, and I'm not fluent enough and my health literacy low, well, I actually understand the instructions I need to do. Is it addressed for me? So, for example, technological solutions in addressing the translation of medical jargon into plain language so that patients can better understand issues that they need to address to better take care of themselves. How can we make sure that health literacy is not a divide? And how can we look at technology to help us assist in really crossing the bridge that we have in health literacy and making sure that plain language is something that we address in giving patients the empowerment to really understand what they need to do to better take care of themselves.
So as the world was shutting down, we all realized how badly we needed technology to stay connected with other people. And it became the only way lots of people were able to access healthcare services. So we saw this incredible potential for technology to improve access to care for people unable to leave their homes, for people in rural communities that would have had to drive several hours to receive their care. But we also saw how relying on technology left some people out. Those are the people that don't have access to good internet, people who aren't comfortable with the technology, people who aren't comfortable in communicating in English, and people who struggle to use devices. This shined light on a whole new set of barriers overnight. And we now know that technology is not just a nice to have for health, it's a must have. And as such, we always need to put an equity lens when we create health tools. Which is all to say, I think digital has an incredibly important role in improving health equity. It just has to be designed to do so. And we need to have the resources to make sure that people are getting the right technology in their hands in a way that is useful to them. To start, I think we need to bridge the divide between the equity world and the technology world, which is what you are doing with this meeting, and which I find is so exciting. Because traditionally, the people who work on health equity don't think through a digital lens, and the people who work on digital don't think through an equity lens. So we need to really be intentional about bringing those sides of the house together when designing products and services. We also need to keep in mind that the digital and the tech world tends to get really excited about the new and innovative tools they can create. And in their excitement, might lose sight of the fact that many people cannot use the tools they're creating. So as new digital health tools are built, it's really important that they're designed from the start to ensure that diverse communities are able to access, understand, and use those tools.
Technology is not going to be helpful if the technology hasn't been adapted for the needs of the people using it. So that may mean that there's language and linguistic adaptations, that the accessibility features are available. So for example, if somebody has tactile difficulty typing, enable the dictation mode, enable use of changes to the monitor, to enlarge the text, for example. So when people have those kind of barriers, the technology has to be adapted to address them.
I think that we have a way to go in helping us deal with all the challenges that I talked about before. The financial, the technological, the cultural, the ethical. But I think one of the major problems that we have now that we need to work on is the integration between systems within an organization and between different organizations. When we manage that, and that is a complex thing, we'll be able to provide a much better continuity of care for our patients, to all our patients, and it will help us do a better job controlling the patient's diseases.
To resolve it, we need to do several things. First and foremost, we need to involve developers from different populations, and when we come to solve a technological problem. Second, when we develop a solution, we need to ask ourselves who can benefit from it and who can lose from it. I can give, for example, the closing of the bank branches. It's not related to health, but when we closed the bank branches and moved to online services, population who were less oriented to technology suffered from it. And this is why when we develop health solution, health technology, we have to know for which population we develop the technology. We cannot develop one technology to feed them all.
So, easier said than done. How do we do this? I'll offer 4 practices that I think will really help get the field moving in the right direction and are relevant in the US and Israeli settings. So one is engaging diverse communities, patients, and providers in the design of digital solutions. Healthcare organizations and technology companies can actively engage diverse groups when they design and implement digital solutions. So stakeholders, particularly technology developers and funders who may be less familiar with those root causes or social determinants of health inequities, need to understand that these societal factors are an essential part of health outcomes. By involving those providers and stakeholders, they can design a product that meets the needs of everyone with a focus on the end users of the product. This involves making a conscious effort to include those diverse stakeholders as part of the development team, including patients, community members, and anyone who they really want to be using the tool. It's important to understand that people from different backgrounds bring varying perspectives to the table that can contribute to a better and more inclusive product. 2, we need to be designing around the needs and capabilities of the end user. So in order to meet people where they are, we need to understand where they are on the digital continuum. So this enables us to design tools around the needs of the most underrepresented and at-risk communities. So we're thinking about accessibility and appropriateness from the start of the development process. For instance, if there's an issue with access to smartphones, one popular solution that we're seeing is using mobile technology or SMS to provide information and an access point for patients to connect with their healthcare providers instead of having to rely on the internet. A third, I think digital navigators can be a really powerful tool to train patients to use existing digital tools. As I mentioned before, digital health literacy, which is the ability and confidence to use digital tools, is a significant issue, particularly for older populations and people who might not be familiar with the language that the tool is developed in. So digital navigators can work with patients on these new technologies like telehealth platforms so that next time around they'll have the confidence to use it themselves. And then last but not least, this is number 4, we need to keep asking questions. No one has this figured out yet, and digital health equity is an iterative process. But as we move forward, we need to keep asking who's included by this technology and who is excluded. This makes sure that we're always being mindful of the health equity implications of the tools we're creating. And we can't wait for a perfect solution. We all need to be working on this, and we need to be working on it now.